Yeah, thank you everyone for attending this second lecture in the Dr. Farah's expert series. Again, we're proudly to present this by Cyber Patients Expert Series with the goal of connecting students in healthcare with an international cast of expert medical practitioners through educational and interactive talks. We take a closer look into specialties in medicine. So this series is then going to form a part of the additional educational resources and a platform available 24/7 to all Cyber Patient users. And we recommend, even if you don't have a premium Cyber Patient account, please go ahead and try out some of the, with a free account, you can try 3 different COVID-19 related cases that involve some ethical decisions. So those are the cases we're trying to highlight in parallel to this lecture series. And yeah, please give that a try, and we will give feedback, and you can see how well you do and progress throughout those cases. So I'm going to just copy and paste this in the chat box. If anyone has any specific questions about Cyber Patient cases or the platform, please feel free to email. All right, so with that being said, Dr. Perez, how is the, I can see your connection is a little bit,
okay.
Audio is coming across, which is good.
Perfect. Thank you, James, for your kind introduction. And good morning, or good evening, good night, wherever you are. Thank you to the executive board of Cyber Patients and to my good friend, Professor Karim Quayumi. The topic we are going to address this time is the patient-physician relationship and the communication between the physician and his or her patients. So I have disclosures to mention, and this is the structure of the lecture. We're going to make a brief introduction in order to frame the issue. Then we are going to focus on the physician-patient relationship and the communication, which is the basis on the ground for this relationship, and some recommendations for you to take home, which will undoubtedly serve for your purposes as a future physician or a novel physician in relationship to your patients. So we're going to, this gentleman is Abraham Berese. He's currently vice chair of internal medicine at Stanford University. He was born in Ethiopia, Addis Ababa, and his family moved when he was 3 years old to the US. Then he returned back to India because his mother was of Indian heritage, where he graduated at the University of Madras. He returned back to the States to complete his training, and he moved along many places in the Midwest, including Tennessee and Oklahoma. His story is a story of resilience, and Cutting for Stone is his last novel, who was in the first place, according to the New York Times and the New Yorker. And he's about his calling to become a physician, and also about the relationship between a physician and his or her patients. And another detail that you need to know regarding Professor Bergese is that he was one of the infectious disease physicians who was in the first time struggling against the AIDS epidemic in the early 1980s. So I recommend the novel, which is part autobiographical, and I'd like to start this lecture with a quote from his book, from his novel. But I also want to quote Oliver Wendell Holmes. His son was a prominent member of the US Supreme Court of Justice, and he was very clear in his medical essays, not only to be consistent, but also to be true in your relationship and communication process with your patient. And also that what you need to know and what the patient needs to know and what do you need to inform the patient. Harvey Cushing was the developer while he was at Hopkins of neurosurgery should be credited with expanding specialty. But look at how he wrote and how he put very clear his mistakes. And he, speaking of himself, he mentioned the misjudged procedure evidently turned the balance against the patient. And it should be remembered that the Baltimore Sun, circa 1905, published most of his failure. Remember, imagine at that time any neurosurgical procedure. So the Sun printed the name of each patient, the distance he or she had come to undergo a neurosurgical operation. A few days later, they ran up a follow-up story announcing the patient had died. Mortality at that moment was close to 90%, and very few could survive. And Walter Dandy was one of his proteges and mentees. And look how he wrote about the procedure of ventriculography. It's very dangerous. There has been a tremendous mortality from its use. I have 3 deaths at the beginning of the series, probably which should be attributed to the curve of life of future experts. So this was the way communications and bad events were communicated at the starting ages of the 20th century. And of course, they want to parallel the relationship between the patient and the physician, because if the patient requests antibiotics for the cold, the physician will be slap the face and say that's virus and there is no need. So this wants to embrace and to make a little bit of fun about the miscommunication between this therapeutic alliance between patient and physician. And for you, I believe that most of you sorry for the interruption, but seems that the internet connection here is a little bit unstable. And I was speaking about James and his first experiences as a medical student with Mrs. Robinson, and how he reflects that he didn't wait to hear what Mrs. Robinson, had to speak, but then he discussed with his instructor, and then the final result is that Mrs. Robinson is very happy because she thanks for listening, which really helps, and it was a pleasure, and how he reacts. So this evidence what's going on in the real world of the patient-physician relationship. And of course, one of the big issues that we have nowadays is the medical record. The electronic medical record takes plenty of time, so many times the eyes of the physician will be not addressing the patients. There were not the eye contact, but the physician will be focused on just documenting the medical history or completing the medical record. And for example, it has been studied that for a 5-year training surgery, surgical residents spend about 8 months per time just sitting in front of a computer and completing the electronic health record. So it's when you communicate with your patients, and sometimes you will communicate bad news, your words should go through 3 filters. The first reply to the answer is, it is true. The second, is it necessary? And the third, is it kind and gentle? So when your words go through these 3 filters, you are ready to start communicating with your patient and announcing what's going to be good news or bad news. So, of course, there are different ways of communication, and it's not the best way to go. The patient's physician is not a contest, it's not a challenge. This needs to be a dyadic relationship, working for the benefit, the mutual benefit, specifically for the benefit of your patients, because you are a fiduciary of the patients. And of course, communication is 95% of the time the root cause analysis evidences that communication breakdowns are at the bottom of any adverse event for medical errors. And when you can to develop trust between the patient and the physician, that lies at the cornerstone. The only way to keep this arch in this position is through the presence of this keystone. And this keystone is what I want to represent, not only as the trust between these two parts of the dyadic relationship, but also the initial statement for effective communication between the physician or the therapeutic team and the patient and his or her family. Look at some data. Physicians interrupt conversations within 10 seconds. Try and see that this is really the way we go. So there's plenty of things that we can do to improve this communication. 54% of the issues and 45% of their complaints are neither obtained by the doctors or referred by the patients. So we are not being effective at interrogating and speaking with our patients. Patients and physicians do not agree about the main clinical problem in 50% of the visits. 63% of patients are not satisfied with the information provided. And of course, many patients agree in the lack of emotional support from part of the physician. And this is related to the degree of specialization that the physicians could evidence or demonstrate. And this has been very well received by cartoons. As you can see here, the doctor will see you now, but the nurse cannot promise that he will talk to you, but he will see you. So which is the sense? And this is a real thing and real life, specifically when with the surgical professions, which are justified by the well, he's good, she is good, but not that much. So they are not empathic with the patients. And this is what you need to know in order to be successful in this therapeutic alliance between the physician on one side and the patient on the other side. Look at the patients, remember, very little, 60% after the first visit, but it goes down to 12% after the month. So patients do not recall the information you provided. So this may compromise the informed consent process, specifically if a patient is going or has a future surgery schedule. So the Institute of Medicine Goals for Healthcare requests 6 conditions. Specifically, I will focus on the patient center. Everything has to have the patients at the core of your horizon. Should be timely, efficient, equitable, which is not many times the case in countries around the world. But also, you need to provide trust, knowledge, regard, and loyalty. And that added to the mutual desire to improve outcomes. And this mutual desire has to be on both sides of this relationship. And of course, it has been proved that the better the relationship between the patient and his or her physician is, the better the patient outcomes, and the most the patient will follow the prescriptions from his or her physician. So it's important to achieve a bond, a link, a relationship based on trust between you and your patient. Edmund Pellegrino is known as an ethicist in the medical field, and he defined and precise different models of the physician-patient relationship focusing on the role of the physician. You have the clinical scientist, the body mechanic, the businessman, that who could be assimilated to social servant. And the most important, his recommendation was the last one, the helper and the healer. If you are not able to save, you need to comfort. If you are not going to provide a curative therapeutic, you need to comfort the patient, specifically taking into account the agony and avoiding futile treatments. Both Emmanuels, they consider 4 models of the physician-patient relationship. We start with the paternalistic, the deliberative, the interpretive, and the informative. But I believe they lack in a relationship where you can improve the therapeutic alliance between physician and patient, and also this shared decision model where the patient is part and is able to make decisions of his own according to the recommendations which provided by the physician. And of course, different factors which affect this relationship may be dependent on the patients, on the provider, on the health system, or there is a patient-provider mismatch. Because it's an important thing. Things have changed in the medical care scenario, and right now there is no freedom of choice, not on the side of the physician, but worse, on the side of the patient. Many patients, according to their social coverage, are mandated to go to center number A or number B, but he or she are not allowed to make a free choice of the place where they want, because there is no coverage or there is no chance. Otherwise, you have to incur in out-of-the-pocket expenses. And of course, there is an active-passive model regarding the patient-doctor relationship, more related with the old antique, I would say, or vintage paternalism. However, many times the paternalistic approach is necessary. Imagine an emergency physician who receives a patient who has suffered trauma, accident, and he or she are under the effects of alcohol. Well, they become unconscious. So the surgeon, for example, in this case, if he or she considers there is a need for a surgical operation, an emergency operation, they need to proceed. And many times the patient is not in a condition to provide informed consent, and there are no surrogates or relatives. The guidance comparison model, and the best of all, the mutual participation model, which should be regarded as the best model of doctor-patient relationship. It will also of another important point, that the physician that tends and plays a role as an authority, which is based on his or her expertise, wisdom, concern, fiduciary wisdom, and his care for the patient. Meanwhile, the patient holds a position in authority, allowing that upon his or her body, something is going to be done or not. And this is crystallized by the informed consent process, which after receiving adequate information, processing, understanding it, the patient says yes to a therapeutic proposal, say no, and that's the freedom. As we see in the previous lecture, this comes from the Greek times where you have slaves and free citizens. And of course, I'm against the provider-customer relationship, as many times the physician-patient relationship is known. I'm feel myself not a provider of care. I'm a physician. And my patient, who is a sick person and who is in a vulnerable state, is not a customer. He or she are requesting healthcare or surgical care, which is my field of specialty. They are not customers. So beware of this big difference. Let's move on how you communicate with your patients. And there are different, in this slide, you will see different definitions of communications according to the Oxford Dictionary, Cambridge, the Webster, but it's basically the communication between one and another person by which it's a process where a message comes from one place of one person to another person and vice versa. So there are different stages. There is an intent to communicate. You have to complete your idea. You have to compose with words your message. You need to encode. And also, it's not only about the word, but the paraverbal, the non-verbal means of communication. How you let the channel you are going to communicate, the tone of your voice is going to be written, it's going to be spoken, which is the face you are going to be smart, are you going to be somber, you are going to denote you are angry, how the transmission is performed, and when it comes to the other person, he or she needs to decode, perform the interpretation, the understanding, and provide feedback in the sense that he or she understood the message that was sent by the other side of the team. And in the intention, you have to compose your message, you have to speak or any other means, as I mentioned, and then reception, decoding, and interpretation by the other side. But beware, because there are different factors that influence how you receive, how you decode, how you interpret, which are related to the health literacy of the person, the values of the person, the beliefs, not only religious, but in any sense. And so here on one side we have the patients, and then on the other side we have the physician. At the top, the physicians provides information, and here we have the receiver, the patients, and on the other side, the patients is providing information to the receiver. But any two ways may be interrupted by what you call noise, interferences, drawbacks, interruptions. So beware that you may say A, and this may not be understood by the patients. And the patients may refer to his or her complaints, and these complaints may not be fully understood by the physician, who in this case is the receiver, due to the noise within the communication process. And of course, we need to know who the patient is and what he or she are ready to hear. Otherwise, we are going to fail. So we communicate. It's not only about the spoken word. We need to look, make eye contact. We need to interact. We need to touch the patient. Imagine a consultation where you do not touch the patient, you do not examine the patients, you just rely on the complementary studies, X-rays, CT scans, MRI, etc., etc. You need to listen. You need to show empathy and compassion, and you need to provide a therapeutic presence in the sense that you are fully committed to solve the problem that the patient brings to the consultation. And he or she needs to be absolutely aware of what's going on and of your concern. As I mentioned, communication is not only about words, but also about the nonverbal and paraverbal component. And as you can see there, how do you look at your patients? Do you make eye contact? Do you touch? How do you see their complaints? How do you assess their feelings? How do you connect with the patients of the family? Do you go to the ward, speak with the patients, and then perform an assessment? How do you think the other part understood what you have just said, and you following day. So it's important to reflect about these issues. And of course, you need to establish, and everything is consequence of the trustful relationship that you are able to start, the rapport, the relationship. It has to do with attention, it has to be with nonverbal synchrony, with positivity. And remember that this encounter is not only medical, but it's a human moment where the future of the patient many times is played, because if the patient does not develop a relationship based on trust, probably he or she will say no to the treatment. And imagine if there is a colorectal cancer with risk of obstruction. So you need to be connected, close, and be affectionate. So communication always, as I mentioned before, and as requested by the Institute of Medicine, should be patient-centered, which is the effective communication that obtains, understands, and validates the perspective of the patients. Remember that when confronted to the question, what would you do in my place, doctor? You need to be in the place of the patient, not in your place. You need to know the values of this patient, and you need to know which is his or her perspective. And how you are able to discover this? Just by talking and communicating. When you provide the information, this information will go through different filters, which has to do with the perspective of the patient, the experience of the patient, the knowledge. Nowadays, Dr. Google provides plenty of information, not peer review, but at the end of the day, it's plenty of information. And also, but the reality of the society and the expectations of success. Most of people consider that when confronted to an operation, the patient will not listen to the risk, to the failures, because they think they're always going to be on their side, which is successful. And that many times happens, and this is many times the trigger for malpractice litigation and professional liability claims. And of course, in order to improve communication, you need to be motivated. And this is really an attribute of young faculty and young physicians. You need to be able to get to the core of the patient's problem. And of course, you need to behave as a professional during this therapeutic encounter. If provided requirements of this effective communication, it needs to be simple enough in order to allow general understanding, but complex enough in order to understand the clinical situation, the prognosis, and the risk. You need to involve all the players, and we mentioned all the players, not only from the clinical team, but also from the family, the surrogates, and all those involved as relatives. And also, all this is applicable to the clinical communication and the relevant results. Think about the patient when they goes pancreatodenectomy, we will proceed, and he or she will going to stay at least 10 or 15 days and may have their chance to undergo difficult and different post-operative complications. You should be aware of all this when you provide information to your patients. Of course, there are reference frames that you are going to be, you can read detail when after this lecture. Also, regarding the relationship between, the relationship between litigation and communication, and this is a paper addressing surgeons who have been undergoing a sue. The people don't sue doctors they like, so you need to be liked by your patient. You need to build a relationship grounded on trust. The surgeons who have never been sued spend more time than 3 minutes longer with each patient than those who have been sued. speaking 3 minutes longer. This is really unbelievable. So, and you need to be cautious when you make comments regarding the prognosis to family, etc., etc. One of my first mentors always told me that what people request is time. They will forgive. They will forgive any mistake, any complication, any bad outcome. But what will not forgive is the lack of time to provide care for the patient and attention to information and detail. And of course, if you want to know a little bit, to know how a framework of how to improve, you are just starting your professional career. Well, you need to develop and stimulate healing relationship. You need to exchange information. You need to give reply to emotion, be empathic. You need to manage uncertainty from every side. You as a physician, you are going to have uncertain regarding the prognosis. The patient will be uncertain about what's going on with his or her health. You need to be collaborative and supportive in every decision the patient decides to, and you don't need to criticize. And you need to allow and promote the patient's self-management. Some of the tips also, I always will start and stress allow time. That's very important. And consider the physician-patient relationship as a partnership. The goal is the patient improvement. Some tips to facilitate and ease the behavior. Just questions. You need to allow time in order the patient to communicate. Many times after the first 10 or 20 minutes, you are going to receive information regarding the real issue, which is motivating the consultation and the scheduling an appointment with you. It's not when the patient is not going to start from the minute 0 to start, I'm going through this, that. You need to create an atmosphere of trust and relaxation in order that the patient can be feel safe in order to provide information. Another, here you continue with this, and we are going to drop. The silence are very important in this communication process because you need to give the patient enough time to complete and to continue story and not interrupt, as you see in one of the first slides, before 18 seconds, which is enough. You need to accompany the words with your eyes, demonstrate that you are listening and putting attention and not focus on your cell screen or your notebook screen. So this is important. And always, many times it happens to me, I see many patients as second opinion, and when I invite them to undress and put a robe, but you are going to perform a physical examination. Okay, of course, there's no doubt that I'm going to examine you. Because I have all these boxes with plenty of radiographs and CT scans, etc., etc. And that allows touching the patients is another way to establish an effective communication. That it's important. And many times what you see is that what I call a group of surgeons. They are not surgeons of patients, they are surgeons of diseases and surgeons of images. It's just all about that. They do not care about the patient, but only about the evidence. And many people are going to be guys. And how we need to react. We don't need to get angry because the patient, remember, is always in a vulnerable situation. He or she are looking for help, and you need to show empathy, listen, trying to understand, asking questions. You need to agree with some way of critique. It makes it possible that I agree with, but, and of course, feedback and negotiation. And you need sometimes to encourage the patient, but sometimes you need to say, I am sorry. And this is where, specifically when confronted to medical errors that we are not used to pronounce. And many times what the patients and the relatives are expecting is an apology, just to say, I am sorry for what's going on. To mention the communication with an adverse event or medical error has been discovered in the process. And here you need to communicate and disclose the error to the patient, to the relatives. You need to file an institutional complaint, and probably you need to report and collect to the risk management office. So this is very important when in knowledge of the occurrence of an adverse event or a medical. And just sizing a little bit, we're going to provide the following take-home messages. Good communication helps both patients and doctors, and empathic communication improves outcomes and patient satisfaction. This is usually taught in medical school, it should be, but it can be very easily learned and needs to be practiced. And in that way, our patients will be thankful. And of course, effective and trustful and empathic communication diminish the risk of malpractice litigation, which in many places, many countries is an endemic. 10 tips. Build a bond, show empathy, understand the patient's perspective, place yourself in the patient's feet. Speak clear and speak simple. Many times when you are announcing bad news, you use the jargon of medical terminology and the patient or the relative do not understand a single word of what you are saying. Not even you or some of the colleagues mentioned. Time to update, time to provide information, time to reply answers. And also you need to be available and always arrange for the following encounter. Always favor second opinions because they will probably reassure the family and the patient of your behavior. And always make eye contact. Never watch the ceiling, the floor, or above the shoulder, because the people will be really upset, especially the relatives. And I would like to end with this quote from Elizabeth Kubler-Ross, who was a distinguished internist, oncologist, and psychiatrist, who wrote a book about death and dying. Speaking about the patient, she said the following: he, the patient, may want one single person to stop for one single minute so that he can ask one single question. But he will get 12 people around the clock, all be preoccupied with his heart rate, pulse, electrocardiogram, or pulmonary functions, his secretions or excretions, but not with him as a human being. And this is what Elizabeth Kubler-Ross highlights, is that we need to take care of our patients as a full and holistic human being, as a human individual, the same as us. We're requesting our knowledge, our expertise in order to benefit. With this, I'm ending my lecture, and I'm more than happy to take questions or comments. I'm sorry if the connection is a little bit unstable, but I hope you were able to follow my words as well as my PowerPoint presentation. Thank you very much for your patience, and I turn the mic to James. Go ahead, please.
Thank you for the talk, Dr. Ferreras. I know there was some connection issues there, but I was able to follow along, which was great, and great presentation. I would just like to invite the audience to participate in the Q&A. If you have any questions for Dr. Ferreras, I've got a question here to start off the Q&A period. Dr. Ferreira's physicians, for example, family doctors, only have so much time to spend with each patient. In certain instances, communication and information sharing may not be the major focus when time is tight. So how can we balance important but time-consuming communication and time management to get around to each and every patient?
Well, that's a big question surrounding all this issue. We need to provide time. Many appointments may be ended in 15 minutes. People who have been knowledgeable, we have known for many years, we have been following for many years. But sometimes the initial scheduled appointment will consume maybe an hour, maybe even longer. The other day, I usually take care of my clinic at the university hospital. I have relatively few patients, but I received a patient who was looking for a second opinion on last Monday. I spent with her about, I would say, more than an hour, because I tried to go. This lady came from another system. She was diagnosed with, she had the suspicion, presumptive diagnosis of carcinoma, the head of the pancreas. She had been performed percutaneous drainage in April of this year. So she wasn't very much willing to undergo additional studies, but I need to convince her that at least we need a new CT scan to assess the relationship between the tumor and the superior mesenteric vessels. She didn't want at first, and I convinced, I called my chief resident, we went, arranged the timetable for her. I thought that she was not going to return back, but thanks to God, she returned. And it's all because the time spent, and as I mentioned before, in 1 hour, I was able to build a relationship grounded on trust. The lady had not trust previous physicians, previous gastroenterologists, the previous interventional radiologists, previous HPV surgeons. She was looking for someone in which she could trust. And I'm going to operate her tomorrow, so that's the good part of the story. So the lady was really thankful that I spent 1 hour. So it's very difficult to manage. Maybe next time when I saw her for the postoperative consultation and follow-up, I will not spend 1 hour, but many patients deserve 30 minutes, 1 hour. It's very difficult. And that's the reason why I refuse to consider myself a provider and my patients customers. Many times, if you are seeing a patient with an inguinal hernia, probably you are going to take much less time, but you don't know what's going on in your clinic and why patients want to see you. So that's part of the fiduciary duty that you have as a physician. It's not about time. It's about solving the problem the patient brings to the schedule.
Thank you for that answer. And thank you to the Q&A question here that we have from someone who's remaining anonymous. The question is, how do you deal with patients that are unwilling to cooperate?
Well, that's a very timely question. I would say it's not easy to solve, but I want to remember that many times you need to address the freedom of choice. If your patient is not cooperating, if your patient does not follow your suggestions, maybe you have I have hypertensive patient, he or she does not take the medication, does not go with the control, does not go with this, with the diet and the different measures, etc., etc. At the moment, it must be, you might clarify the issue that if the patient is not compliant, you are able to end the relationship. This has been every time more and more accepted. This is a two-way relationship, and the issue of non-compliant patients has plenty of literature. So meanwhile, there is no emergency condition that needs to be addressed. You are allowed to terminate this patient-physician relationship.
Excellent. Thank you so much. We'll just wait a little longer here to see if any other Q&A questions come up, but that seems to be all for now.
There are some in the chat. James, do you want me to address some of the questions that are in the chat?
Oh, yeah, sure. Go ahead. I see one there too.
Well, perfect. Sabi Saidi says, effective communication is indeed the building block of patient-physician relationship. Well, fully agree. And that's part of improving and performing better results. He also says, a couple of extra minutes spent in communication with the patient may save a physician months of agony if a compliant is lodged. Not only that, when confronted, for example, to fetal care or care in the last minutes of life, which sometimes is the last 2 or 3 days, you need to know that the medical expenditures, 60% take place in the last 2 or 3 days of life. And many times the communication between the surrogates of the decision maker is pretty ineffective. Because, and we are going to see this when we saw the lecture regarding palliative care and futility care or fetal care. What do you want us to do? Most of the time the question will be everything. Well, everything that may allow good outcome. So otherwise, the family will say, I want everything to be done. And you are confronted to a 92 years old. Many times there's an excess or incarnation of therapeutic goals or extraordinary care, which really is not requested by the family, but is understood in this sense from the point of view of the physicians, and many times just to prevent professional litigation. Let me see. Where can I find the report? Here is another point regarding a non-compliant patient. Should we not try to understand their perspective first, do some shared decision-making and involve them in the process before we terminate? Well, of course, but it always depends about the non-compliant and the degree of non-compliance. For example, when confronted to and I will refer to digestive tract surgical issues. You are confronted to, you have a 79-year-old in relatively good state, ACOG2, who has been diagnosed with a carcinoma of the pancreatic head. He needs to undergo Whipple procedure, which is a duodenopancreatectomy, which is a major and big operation with some risks such as postoperative pancreatic fistula, gastric outlet syndrome, dehiscence of the gastroduodenal anastomosis, and maybe the patient will say, oh, doctor, really, I don't want to undergo such a difficult path. It's plenty of times. I prefer just to rely on chemo, maybe even radiotherapy, or I'm okay like this, and I will just want to palliative care, including relieving the jaundice of the patients, and I'm able to eat, and I don't want extraordinary measures. And that's should not be defined as a non-compliant. That's part of the shared decision process. And you are able to continue managing that patient, and he or she will feel very comfortable when you addressing the issues and being involved in palliative care. So, well, of course, and you mentioned cultural or religious issues. Perdigo Gianni, sorry, because I believe that's your family name. I mentioned in the first lecture of this session, the case of an Eskimo chief who was taken care at the University of Washington, and he refused to get care because he considered that he has not been well treated because he was invited to participate in the decision-making process. And according to their culture and values, that's contrary, absolutely contrary to their uses. So our lack of previous knowledge considered that, and then the patient was referred to another physician, to another surgeon, and we could go through, and with the aid of one of our chief residents, herself an Eskimo descendant, we were able to solve the issue. I fully agree. Regarding the question forwarded by Monica Rueda, how do you end the relationship with the patients? One, I would say it's very clear. You have to document this in the patients. And I would suggest always to send the patients to another colleague in the same field of specialty. And of course, I need to warn you, if there is the slightest risk of emergency care, you need to stay alongside your patients, and you are not able to terminate this relationship. Vandana asked the following: to what extent do we need to involve the patient's relative in the communication process? Well, that's a very timely question. I like to involve the patients every time that we are able. And there are many reasons to do this. And always, I come always with the bias of being a surgeon. For example, bariatric surgery. Bariatric surgery is a very useful therapeutic tool. It's we can accomplish very good outcomes, but there is a mortality of 0.9 to 1.5% according to the publications. So if the patient dies, the risk will be represented by the family. So in our department, for example, every bariatric patient who is considered competent and who bears capacity to provide informed consent. However, we always request the family to come to some of the lectures and the seminars we offer to these patients in order to speak about adherence to treatment, the importance of the follow-up for the whole life, the involvement of the family, because we cannot operate just a member of the family who is an obese and the rest of the family who are obese will remain. So that's an important issue to take into consideration. But I change also the scenario. I remember many years ago, an 18-year-old with an inguinal hernia. He was absolutely competent and he bear capacity, but I was very clear that I was not going to operate on him if either her mother or her father, their parents were divorced, came before the operation. And the only reason, and I explained, the mother was a little bit upset. I told her that any surgical procedure under general or spinal anesthesia has a very minor degree of mortality, and I wanted to know them if in case I have to provide bad news while I was in the operating room. So it's all up to you, it's all up the culture, but it's not that the relatives will make the final decision. And Another times, also I have encountered a request from part of the family by a previous talk, or one gets into my office before the patient, that they don't want to tell the patients the real diagnosis, or even, I remember once I was requested not to mention that the postoperative course involved staying in the intensive care unit, and I do not agree. I said that there was the patient's right to know what's going on with his body, with the real truthfulness of his clinical situation, and everything was solved. So be careful, but I would try to involve the relatives in the communication process. Specifically, of course, many patients during the postoperative course are unable to make decisions of their own. Imagine a patient who comes to the trauma department and undergoes a surgical procedure and needs to be intubated for about 2, 3, or 4 days. Well, you need to communicate with and involve the relatives, especially if you need to make decisions. Well, Brian, I would say that this is not compliance. This is absolutely justified non-compliance, which can be seen all over some places in low and middle-income countries, and especially in the public or state settings. This is not compliance. Of course, you need to know the details. I'm speaking of the patient with the coverage that's decided on his or her own to manage on his own version of tailor-made the treatment. This is quite a completely different situation. I think we are done with all the questions coming from the chat, James.
Yeah, absolutely. Thank you for really leading that discussion there, Dr. Ferreras. And thank you everyone for sharing your questions and thoughts in the chat. I think at this point we can wrap up the second lecture in the ethics lecture series. Thank you for joining today. Again, don't forget to explore your sub-patient accounts if you don't already have one. You can have access to 13 free cases, including 3 COVID-19 related cases with a free account, and you can test and improve your clinical making skills. Again, thank you so much for taking the time out of your day to attend, and please fill out the survey if you can. And again, thank you so much, Dr. Ferreras, for the great lecture.
Bye-bye. Have a great day or great evening. Bye-bye. And see you next Tuesday.
See you next Tuesday, everyone.
Nice weekend.